I shall present you a failure. Failures are very interesting because we learn a lot of things. We learn about what we did and what we did not do. So I present you this woman, 35 years old, a classical history of low back pain. And you see the level of disability on the right, preoperative. So she's very active, perhaps too active, you will see. And she was treated for more than 1 year with medication and physiotherapy. Something classical with narrowing of L4, L5. You see the modic change on the RMI, and you see there is a slight inclination of the spine on the large AP view. Now you have the EOS, and the EOS provide us an additional information. She is not imbalanced. She has quite normal incidence angle, and she is a little bit retroverted with sacral slope 28. So nothing very particular. Sitting position, because I do always sitting EOS as a research, but I think also it is very interesting to see the evolution of the patient and to understand some particularities. So she is not imbalanced sitting. What we can observe when comparing standing and sitting is the disc is very stiff and narrow, is very narrow in the anterior point of the disc space. Another detail, you see that the modic change is very particular. It is on the right side. Remember, she has a slight inclination of the spine. And so when you go from the left to the right, you see you don't see the modic sign on the left side of the vertebra on those sagittal images. I do systematically an angiogram, and you see she is classical, no particular, no specific complication to be expected. So this is a post-operative image, September 2015. We had no per-op or post-op problem. Perhaps you can criticize me. Perhaps it would have been better to push the prosthesis a little bit more posterior. But with viscoelastic, we know that with such positioning, we don't have problem. So she was in a good situation post-operatively, and we saw her. I see my patient 1 month after, no problem, and 3 months after, you see this patient in December 2015, and I discovered that this woman had a lot of activities, and I found that she was a cocaine user. So you can criticize me and say, bad selection of the patient. I assume this, but perhaps it was not fully a contraindication. But the point was, she did not use a brace. And I fully agree with Patrick saying that the limitation of movement postoperatively is something interesting during the bone ingrowth or the bone on growth period. And you can see that something worried me. You see a radiolucent line on the upper part of the prosthesis. In addition, and I am not sure it is a good sign, she had a bending, and you see that on the right bending, the position of the spinous process is slightly rotated on the right. Those two arguments made me a little bit anxious, and I asked this patient to wear the brace. Now you have the follow-up of the patient 6 months after the surgery. She is still in good condition. You have all of the parameters on the right of the slide. And again, despite she is in perfect situation clinically, she is very active, and you see that she has this radiolucent line at the upper part of the implant. So I was anxious, and she was lost for follow-up for 5 more, a little bit for approximately 5 years. You see, she became homeless, living in a car or in the streets with a lot of drug and alcohol use. And in addition, she had a severe traffic accident with an open forearm fracture. And what the information I got was a fracture of the upper L5 end plate, an impaction. I don't have the X-ray, but you will see what happened. This is what I discovered in June 2021. Impaction of the vertebra, L5, and mobilization of the disc, not in the sagittal plane, but mainly a kind of rotation and impaction. So we need to go in depth now in this case. She came with an RMI. You see on the plane X-ray, she has an hyperdensity of the L4 and L5 vertebra. There is an impaction in L5, probably the consequence of the fracture. And you see an hypersignal of the inferior plate of L4. But this RMI was a little bit disappointing. I want to share with you the analysis I did with CT scan, and I think it is one of the messages. Look at this. When you compare the image of RMI and the CT scan, you have much more information. You see the radiolucent line on the two end plates. So you ask yourself, probably there is no bone on growth or mobilization of implant. And you see a loss of bone material at the superior end plate. And you may ask yourself some question about the density of those vertebrae. So the question are, bone analysis, what about this cyst? What is the bone fixation status? Failure for bone and growth, perhaps septic. And the last question, what about the implant alteration? Do we have bone loss due to wear, or do we have bone loss due alteration of the PCU? First question, bone analysis preoperatively. You see here the detailed image of the superior end plate, and as we use titanium end plate, we are able to have very precise analysis of the bone stock of the patient. And you see very well the loss of bone stock. This is the inferior plate. You have the cut through the implant, and you see also in the inferior plate, you don't have cyst, what I call cyst, but probably it is not the good word, and you have this hyperdensity. But we can be much more precise. We are able, with a CT scan, to analyze the density of bone. Patrick spoke about the DEXA to analyze the density of bone. We can use the CT scan as a tool to assess this. We have the density of the spongious bone, and on the right, I put the density of the spongious bone of other vertebra of this patient, quite the same. And you see the hyperdensity of the bone as a reaction. And you see it's a little bit less than cortical bone, but it is very dense. If we analyze the cyst, sorry, I want to go back. Okay, if we analyze the cyst, you are also able to analyze the inside. And you see that the density is about 53, 65. It is even 44 like blood. And you see a kind of false membrane inside of this cavity. So for me, before doing the resurgery, it was blood, and probably it was serohematic liquid inside of the cyst. So what I did, July 2021, I did a one-stage surgery without technical issue. Stage 1, posterior fixation, because I was a little bit anxious about the difficulties to correct the frontal plane. And after, I did a replacement of the prosthesis by a cage. I don't show you the further slide because it is not important for our discussion. She is well now. And what I discovered was very partial bone on growth. Bone loss, the inside of the bone loss cavity, I had blood and a peripheral membrane, as we see in hip or knee cyst. I am also a hip and knee surgeon. It was exactly the same aspect as we have around our hip or knee prosthesis sometimes. No macroscopic inflammation and no macroscopic implant deterioration before extraction. So I tried to keep the implant intact to analyze this implant. So what about the bone on growth? I had only very limited bone on growth, as you can see. No more hydroxyapatite. It's normal because of the delay. Only small bone on growth. But one of the message was, on the 3 weeks late culture, we had positive samples. All the samples were positive for Propionibacterium acnes. We call this now Cutibacterium acnes. So we treated with this patient with 6 weeks amoxicillin, which will be, perhaps we shall discuss about this, because it is not very classical for hip and knee prosthesis contamination with Propioni. So it worked very well. What about implant alteration? Probably you are waiting about this. And unfortunately, I had to damage a little bit the implant. You see here the places where I put a very strong tool to remove, to track the implant. But I had, before the extraction, no argument from visual observation for a lesion of the implant. And in addition, when analyzing the implant, we put a lot of attention on the top shutter to see if it was still well sealed and to see if there was some correlation with the bone loss in the inferior end plate. What about the status of the PCU? You have the spectrum of the PCU of the implant with a black rectangle, and you have the reference spectrum. It was exactly the same. No, we can affirm that there was no modification of the PCU. Histologically, we did not find hydroxyapatite particles in the surrounding of the implant and no inflammatory reaction, which is strange perhaps, but which is classical also in Propioni infection. So what did I learn from this case? First, the likely scenario was doubtful bone on growth. This patient did not accept the brace, and I was very anxious since the beginning. Probably a worsening of the situation by this asymmetrical compression fracture of L5 and additional delayed septic complication. Delayed or not delayed. We had a perfect follow-up. We did not have any doubt during the first 6 months, but we know that with Propionibacterium acnes, it may be a question. So my first message is, if you have to remove a disc replacement, whatever the type of implant is, we need to do late culture. Second thing, CT scan is more contributive than RMI for those lack of bone. It is not perhaps clear for a spine surgeon, but it is very clear for knee surgeon. I took this image from classical literature for knee cyst, for example, and you see in the middle, we have much more information from the CT scan, the density, you have the density inside of the cyst and inside of the reaction around the cyst. Probably there is a new focus regarding the bone adaptation regarding implants, because we have a lot of patients with not perfect disc and plate. They are curved, concave. You can see on the arrow in those degenerative discs, if you pay attention, you have a lot of such cysts in the end plate of degenerative discs. So it is very interesting to use a CT scan for this. And there are some papers. This paper, I put the reference in European Spine, showing the importance of the analysis of those end plates because of the risk of mismatch between the end plate and the implant. It is a problem, for example, for keel implants. Look at this case. 1 month, I am still anxious because there is a radiolucent line. 6 months, it's much better. 5 years after, completely healed. And it is my experience in a patient with acceptation of the brace. And the last thing is regarding this bone adaptation for disc implant is what is called the external hydraulic theory. It is used for knees, for example. It means that if you have an end plate and if you have a space, you have fluid intrusion and from holes or from the space, and there is overpressure between bone and the end plate. And this may induce, as a consequence, the creation of those bone loss. So we must be very careful for the preparation of the end plate. And in my experience, the inferior end plate of L4, for example, or the inferior end plate of L5 are sometimes difficult to prepare because we don't see very well during the surgery those end plates. Thank you for your kind attention.